we are asking back Andrea Weghofer, who is going to address another rather controversial issue. And again, an issue where some pretty prominent opinions out there do not necessarily reflect reality. She's talking about the association between gonadotropin dose and aneuploidy.
Thank you very much, Norbert. Again, no relevant conflict to declare. Norbert assigned that talk to me because a couple of years ago we published data in fertility and sterility and in human reproduction on whether the supplementation of LH has an impact on aneuploidy risk. And giving lectures on that topic, I finally got to know Esther Bart, a very nice European colleague, and she really started the discussion on whether dosage of gonadotropins we give really impair pregnancy potential by increasing aneuploidy rates. Because what Esther and her group, the Bart-Pfizer group, found that couple of years ago was when they randomly assigned patients to either conventional or mild stimulation and then performed PGD on them, or rather PGS, what they found was they got more eggs, they got more embryos, but the number of euploid embryos remained the same. And that suggested that we are producing considerably more aneuploid embryos by increasing gonadotropins. And at that time, that was a huge issue because the question that eventually arose is, does stimulation impair the selection of the perfect and finally the successful eggs? Frank would be happy to see that because that's probably the slide that was shown mostly during those days. But it perfectly makes the point we need to have a brighter vision than just looking at those very last 2 to 2.5 weeks of oocyte development. But the gonadotropins really kick in during those last 2 weeks. So the question that is proposed is, by increasing the dosage, do we impair that selection? Are we getting the rubbish out of the ovary, if I may plainly define it that way, or what's behind that issue? And again, in order to answer that question, it always makes sense to go back to those people that have the highest pregnancy potential. And reviewing the literature on that, I found studies on oocyte donors that fulfilled that criteria from the same groups, 2 different studies performed, you see, in 2010 and 2012. They have a lot of experience with egg donation, and they randomly assigned oocyte donors to either conventional FSH therapy or low-dose therapy with 150 units in one trial. And the second was even more pronounced, comparing donors with unstimulated, and I'm definitely positive in that, with unstimulated cycles compared to conventional IVF. But when you have a look at the results, again, 225 versus 150 units, you have the impression that Esther was right. Apparently, what they found was, again, the significantly different proportion of euploid and aneuploid embryos, resulting in the same number of chromosomally normal and abnormal embryos, irrespective of the dosage given. However, when we believe those results, it would make sense that they should be even more pronounced in those women with unstimulated versus stimulated cycles. Again, healthy oocyte donors And again, the same group, so we have the same techniques applied to the same people analyzing the embryos. But, however, the results were totally different. No difference in the mean number of chromosomally abnormal rates per subject. So those effects could not be translated. So the question to ask is, what really does influence aneuploidy rates? And we know that it's maternal age, and we know it's the number of oocytes retrieved, and we will come back to that a little later on. But that review nicely showed that apparently it's not the total FSH dosage we are given that is affecting aneuploidy. So what are we doing with these results? We have a lot of controversial evidence on that, and we need to make a final decision about what we think about it. And once in a while, when we have controversial issues, the bottom line question is, do we ask the right question? And within the last days of that conference, you have heard the word mosaicism. You've heard that it makes a difference not only when the problems with the egg and the embryo in terms of chromosomal normality and abnormality arise, but it makes a difference how the egg and the embryo manages to rescue from the trisomy.
That's fine.
And one would assume that if gonadotropin dosage really has an impact on aneuploidy, we should see it in the oocyte. With the meiotic non-disjunction, that is true. The oocyte is already aneuploid. But we need to keep in mind that not only self-correcting purposes may have an impact on that, but that the number, and quite significant of numbers of embryos, do not gain their problems at the oocyte level, but during mitotic eras, right after fertilization. And even those embryos have the chance to repair themselves. So the question remains, is PGS that we are addressing or using in order to evaluate that question really the right tool? You know that embryonic self-correction is probably the hottest topic we discussed here. So the question is, if the embryo can correct itself, wouldn't it make a little more sense to look into miscarriage and live birth in order to answer the question on gonadotropin dosage and aneuploidy risk? And a very large series of cycles tried to do so, but I would like to draw your attention to the fact that SART data was used just addressing fresh cycles, not cumulative live birth rates. But when they analyzed more than 600,000 cycles, they said, well, apparently in good prognosis patients with a lot of eggs, it appears that the more gonadotropins we use, the higher aneuploidy rates we get. However, that does not appear to be true for those women, the regular patient population. I may say for those women above age 35 with a limited amount of oocytes. So why, again, that controversial issue? Please keep in mind that women that have more oocytes and surplus embryos that can be cryopreserved may not experience the real proportion of their aneuploidy. We may not see really what's going on in their first fresh cycle. It might be more interesting to see how they are doing cumulatively. We have a very prominent group in New York advocating the mild stimulation story. And they recently published such a paper where they included cumulative live birth rates in a randomly controlled trial, saying like, does it matter? We're giving them either mild or conventional stimulation. We are double-checking them for about 6 weeks with repeated the first fresh embryo transfer, and then repeat in frozen cycles, just in order to see whether live birth makes a difference. And even though the design was not perfect, honestly speaking, what they really showed was mild stimulation significantly lowered cumulative live birth rates. And if aneuploidy risk would increase dramatically with the more medication I'm using, things would have definitely been different. But again, at the end of the day, you want to know what's going on, and if you question the accuracy of PGS, it probably makes sense to double-check those pregnancies that do not last to term. Analyzing miscarriage material is a different story because you have plenty of cells available and you get probably a more accurate assumption of what's going on in the embryo and the fetus. So, analysis of aneuploidy between spontaneous conceptions and those women who had experienced FSH, who had received FSH either for IVF or undergoing IUI, were compared. And as you see, they are pretty similar in their baseline characteristics. And when you see the karyotypes in those women, you see no difference at all. Aneuploidy risk in those conception is totally the same. So the question again is not only stimulated versus unstimulated, it's also the question, does the dosage make a difference? So they did a subgroup analysis saying like, does it make a difference whether people underwent IVF with higher dosages of FSH or gonadotropins given, or IUI with just mild dosage compared to that what we call mild stimulation in ART cycles? And again, you see, aneuploidy rates were totally the same. However, in the sideline, whatever we see is it really irrelevant how women react and respond to ovarian stimulation? Does it make a difference whether we have to apply huge amounts of gonadotropins, getting out 1 or 2 eggs, or 10, 12, 20? Does it make a difference? And a large PhD group from Generoli and co-workers has said, yes, apparently, it makes a difference how the ovary reacts, what happens in the ovary, whether it reacts physiologically, age-appropriate, or not. So I tried to dig a little more into that and found a huge analysis by Sankara, who did quite amazing work nationwide, blah, 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 whatsoever. And she asked the question, and I think that's a very important one, does miscarriage risk increase with the number of eggs we are getting, irrespective of age? Because if the aneuploidy story is true, it should be comparable within an age group, irrespective of the oocyte numbers. And what you see is the opposite. You see, the bars are how many oocytes we get, and the better the response is, the lower the miscarriage risk. So that leads to the assumption it makes a difference how the ovary works in terms of aneuploidy risk. And as you can see here, again, on cumulative live birth risk, and that's probably the best endpoint to answer that question, the oocyte yield is essential, even more essential than female age. And that was repeatedly shown from different perspectives of stimulation in previous talks today. So the question is, gonadotropin dosage, does it have a negative impact? Maybe not, but the real question, and that brings me back to, are we asking the right question? The real question is, does ovarian response, does ovarian physiology or pathophysiology enable us to self-correct those aneuploidies appropriately? And do we have to have a closer look at those women who are poor responders, who have pathological impacts on their ovarian environment and may not be able to self-correct the aneuploidy appropriately? And by that, I thank you very much for your attention, and I'm happy to answer questions.